All right, we are back with Sofia and Jenny. As we were wrapping up our previous recording, we were then finding ourselves talking off-air about advents. And you said we should have talked more about advents during our last recording. Yes. So here we are, back for take two. That's right. And you're going to tell us a little bit about advents. I am not as familiar as I probably should be with advents. Can you tell us what advents even is?
Yeah, I would love to. So we wanted to leverage the CHND to study AKI, but we found that we weren't really using a standardized definition, the neonatal KDIGO definition for AKI in CHND. So AKI was not captured. It was under-captured. So we've...
And no lab values.
And no lab values or urine output data. So we supplemented the CHND data with EHR data. So we took 10 centers have participated, and they pulled, with a bioinformatics approach, pulled all the serum creatinines for the babies for their entire hospitalization, and then every urine output and mixed diaper.
Did that data help complement the missing parts of the CHND? Which, by the way, when you're saying CHND, you mean the CHNC's database.
Exactly.
Yes. And it's not. So was that complementing, or was that creating a new data set altogether?
Complementing
it, but we have it in its own data set.
For sure. Okay. And what did you find?
Sofia's going to present tomorrow on our findings. We found significant disparities across different maternal race and ethnicities with regard to AKI prevalence and mortality.
Yeah,
I see.
So using white as a reference group, the odds ratios of other groups having AKI versus white was significantly higher, especially for non-Hispanic Black population and Hispanic population as well. It impacted, not only AKI prevalence, but also length of stay and mortality associated with AKI. So, unfortunately, big differences. I do have to say that when looking at the demographics of this data set in this population, African Americans were a little bit younger at gestational age at birth, and of course, gestational birth at weight was a little bit less. So we still need to do a lot of, in-deep analysis, looking at co-founders and everything, but, it's really significant.
Yeah, it's interesting when you stumble upon that kind of data and it opens up a whole new, opens Pandora's box, basically, and trying to lead you into the rabbit hole of understanding why these disparities are being seen. And so ADVANCE is the acronym of the study, or what does it stand for?
It doesn't stand for anything.
Fine.
We just, Awaken was a few years ago, which was the first epidemiological look at AKI in neonates. So we've, that was great foundational work, and we're trying to advance further past that.
Fine.
And that's how the name came along.
Yeah, that makes sense.
We were trying to look for an acronym, but we couldn't find it, so I said, okay, let's advance.
I like that. Awaken, let's pay attention to this with Awaken, and then advance.
Exactly.
What are the next steps?
Yes.
But I think it's so interesting because certainly in the adult population, disparities exist in renal disease. So why would we not expect them to exist in the neonatal population?
Exactly.
So how do you think this impacts kind of long-term outcomes given this disparity data?
Unfortunately, I think that it impacts these families a lot.
Yeah.
So I think that for us, looking into this data is mainly trying to figure out what are the variables, what are these risk factors that we can modify, right? Sure. Because there are going to be some that we are not going to be able to, but I think that we need to put a lot of effort on finding those that we can and work towards that. So I think that this first look was for us to kind of, go on that direction. So we'll see. We both feel like there's a lot of socioeconomical factors and maybe biological factors, prematurity, right? So I think there's so much that we can research in. I think but hopefully we will find something that can help these babies.
Last question for you is, how good do you think we are currently in the NICU at recognizing AKI based on this definition versus just reviewing data that then defines it better? Because I feel like we're very good in terms of identifying the criteria, collecting that data retrospectively, but in real time as we care for these babies. I think these sometimes go unnoticed, almost because our brain has a difficult time just trending and just saying, "Ooh, like this is AKI." What do you guys think about that?
Yeah, I totally think neonatologists, we oftentimes don't give the diagnosis of AKI, or we don't even recognize it on rounds.
Right.
We may think it, but it's not always put in the chart. We don't oftentimes reach out to nephrology when it's needed. But in advance, we have 26,000 babies, and the prevalence was about 30%.
That's crazy.
Wow. 27%, which was similar to Awaken.
Wow.
So a third of our patients have AKI, and I think we really need to pay attention to it. It has an independent association with mortality. So I think we can't really ignore it anymore.
I'm positively not surprised, because I feel like we can recognize AKI, but it's usually the most severe form. Like when the baby has stopped peeing, the creatinine is 15, you're like, maybe that's AKI. Yeah. But it's all these other patients where the trend is just crossing these thresholds that I think do get missed. So it's important to know that the prevalence 30% is it's quite a lot. So
I think that the sensitivity that we have towards this diagnosis needs to go up.
Yeah.
And we're always looking at the specificity, let's say, when we are rounding and so on. So maybe we need to just...
And in that study, the gestational age of the babies you guys collected for was what range?
So we have 22 weekers up
all the way to term?
Yes.
So every baby that you had gone to your
anybody who was admitted
NICU,
to the NICU,
anyone that was admitted to the NICU that had at least 2 serum creatinines it's in advance.
Okay,
that's great.
Very cool.
I think it's so interesting. I think on rounds we're saying, what do I have to manage today? So it's not a number you necessarily manage today, but I'm hopeful that one day we'll say, well, we should titrate our fluids, we should titrate our proteins, there are things we should be doing, maybe tighter blood pressure control, that we really, without the work that you guys are doing, we can't even start to, imagine how the dominoes will fall, right?
Yeah. Or with AI or automation, where the EMR will tell you, hey, like all the values now match the definition. You have a diagnosis of AKI, done.
Yeah.
Like this is.
But I think we feel like, well, they have AKI. What can I do about it? But
for sure.
Hopefully, by better recognizing it, then we'll be able to answer some of those questions.
And we can start with nephrotoxic drugs.
That's right.
Right? So we can start with something very at home and that we do round every day on. Yeah.
I love
Absolutely.
that. Okay.
Jennifer, Sofia, thank you so much.
Thank
Thank
you.
you.
Keep up
Congratulations
the great
again.
work.
Thank you.